joining us today. What we'll be doing in this session is discussing a public health use case so that we can document the pieces of that use case and ultimately identify some places where interoperability solutions, ways of exchanging data more easily in a more automated fashion would really help public health programs today in what they do day to day, how they access data, and how they provide support and services to their populations. And so we have a group with us today from a state program, and we're going to walk through their hepatitis C use case. Some of the things that we'll touch on are shown on the screen here. We'll talk just briefly about what the use case is. We'll talk about the actors and the roles involved. We're going to talk about what triggers the exchange of data, what type of data that is, how the data is used, and how improved interoperability can really bring benefits to not only the public health program, but their trading partners and individuals as well. So we're going to go through a series of facilitated questions with our state colleagues here and learn a little bit more about how they do hepatitis C. So let's start with, if we could, can someone describe the current process as it exists today in terms of receiving data on hepatitis C and any sort of follow-up or work that you do? This is really kind of at a high level. You know, what's the overall goal of the Hep C process within the state? And, you know, what sort of data are you receiving today or going out and actively acquiring?
Yeah, I guess I can start, and then please jump in with anything that I miss. So here we, for hepatitis C surveillance, we are, the reportable conditions for hepatitis C are acute, chronic, and perinatal conditions. And we get most of our reports from electronic lab reports. When the lab send us the results, they are what we call auto-processed, and they go into our surveillance system, CalReady, as a chronic condition, and that's our kind of the default condition. And then we also get a subset of report, a very small subset compared to what we get from ELRs through provider reporting. So and those are acute cases where they the cases meet the acute definition, including like symptoms and other clinical markers. And then we internally kind of track conditions or reports from those individuals less than 3 years of age, and those are considered perinatal infections for the most part, if they're not known to have acquired from other sources than just from the perinatal route. So those are basically the three conditions and the how the results flow in. Anything I missed? Sarah, I know you came on camera. I don't know if you wanted to describe it.
Yeah, I just didn't know how deep we need to go. Like, are you just talking about just like the CalReady aspect? Because that is a very small part of our overall process to the back end, in which we call the actually any of our registries. So I don't know how deep you want us to go.
Yeah, if you could go just a little bit deeper. So what else is involved in the process?
Nan, do you want me to take it or do you want
to?
Yeah,
go for it.
Okay. A lot. So so what comes into CalReady is this like auto, I'm just going to start with chronic because it's the most complex. Everything else is a little more simplified, but for chronic hepatitis C, everything is auto process, auto close as suspect. And we, as you probably know, don't get Los Angeles County data. We actually do get San Diego ELR data through CalReady, but we don't get Los Angeles. And historically, we also haven't gotten San Francisco, but we do have theirs now as well. So the only data piece that's missing in CalReady as of today is Los Angeles County. So what we then do is we have a whole back end process where we take the data from CalReady, we clean it all up, and then we merge it to an external file that we receive from Los Angeles County that's also cleaned. And that's considered sort of our incident level registry. But to be accurate, we have to deduplicate across our local health jurisdictions, because there's a lot of duplication happening in CalReady. Like the data you pull out of CalReady is not usable for chronic hepatitis C. You have to deduplicate it. And so we do that as the next step, and then we identify matched pairs. So then we know, okay, this one person has been reported with 4 different incidents in CalReady, but now we've assigned them like one unique link ID or a unique identifier. So we've now sort of aggregated people, and then we take our incident level registry and we aggregate like the demographics, lab results, etc., to create sort of a person level registry. And then with that, then we go in, and Michael, who is in the office right now, he runs a program that does case classification. So then we are able to apply a resolution status, so we can then decide whether someone is not a case, confirmed, or probable. And then that information is actually read back into CalReady. So that is all done right now on the back end in R. But right now we're also working on snowflakeifying our registry, and we're getting closer to the end of that. So the I2D2 group within CDPH has been working on changing all of our R code over to SQL code, and basically the process is the same. It's just faster and more streamlined on the Snowflake side of things. So eventually we will abandon our R code and be switching over to Snowflake. So that's chronic hepatitis C. And then,
sorry, can I ask a couple of questions first?
yeah.
So you've mentioned CalReady a couple of times. Can you just tell us real quick what role that system plays? Is that disease surveillance, something else?
Yeah, so for chronic hepatitis C, we do all passive surveillance for the most part. There's some local health jurisdictions that do follow up with cases, but yes. So what happens is the ELRs for hepatitis C come in to CalReady. They're auto imported, auto closed as suspect. And there are jurisdictions that may investigate cases, so that is more similar to what other conditions do. But by and large, because the volume is so high for chronic hepatitis C, most jurisdictions aren't doing anything in terms of investigation, but there is space to do that. So that's kind of like the way that we collect our data. It's in CalReady.
Okay.
Yeah, and it's a central system for California for infectious disease, reportable disease conditions.
Okay. And you said you load data back into CalReady after you've deduplicated an identified case. Sorry, I don't want to use the word confirmed cases, but cases. Is that right?
Yeah, we just read back in, like, whether, for surveillance purposes, it's really important that we are classifying our cases as confirmed, probable, or not a case. And so basically we are just only we're importing that one piece of information back into CalReady at this time.
Okay. All right. And you mentioned an incident registry and a person level registry. What systems are those in, or is that just a file you maintain? What's the mechanism? What's the
Yeah, they're
source
right
for
now.
that?
Yeah, right now it's this all R coding in this moment. And these are just like Parquet files that we have that we create out of our R programs. However, it is being like we're in the process of switching it over to Snowflake. And so once all the code is in Snowflake, then the file will all of that, the incident and person level registry will also live in Snowflake as well.
Okay. So are there any data input sources to this process other than that initial ELR report?
Yes, because we get ELRs through CalReady, but we also
Right.
get ELRs
Yes.
directly from Los Angeles County.
Angeles. Okay, right. Yeah.
Uh-huh.
Okay. All right. But you're not going back out to the immunization system and wow, there isn't even a Hep C vaccine, is there? Never mind that
No.
question.
Yeah.
Never mind. Okay.
Yep, unfortunately not. Nope. Yeah, we're not touching on any other systems at this time. I mean, part of that is because our registry broke maybe like 3 years ago, and it's just been a process of trying to get it back functioning again. Because of the large volume of data, we tend to break things. Yeah. But that's just chronic hepatitis C. Do you have any more questions about chronic hepatitis C?
Just one last. When you say you're not accessing data from other systems other than the LA reports, is there data you would like to access and you just can't because the system's not capable of it, or for any other reason, or is this data pretty much all self-contained for chronic?
I mean, I would say yes, there's probably lots of other data sources that we would love to eventually tap, but we haven't had any capacity to do that. And Non, maybe you can chime in here, but in general, we have been trying to just get our registry working, getting a surveillance report out that we have not published since 2020. So, that's kind of like we're working on 1.0 right now, version 1, and that might be like a version 3 dream, because of course we'd want to tap like, birth, death data, but these are all just supportive data sources that would just help us more accurately count cases or analyze our cases in the future for other projects.
Yeah, and I think one thing that I would add also is like even the data from CalReady that we're currently getting, and not talking about other systems, is also incomplete, as in, we really would love to get more complete race and ethnicity data. And right now the ELRs are about 50% of the cases are missing that information. So I think even within the existing system, there are pieces of data that we're not getting that we would like to get.
Yeah, that's a
Okay.
really good point. And that includes even like additional ELR information. Like we don't get liver enzymes, for example, and that would be really nice because then you can determine if someone is chronic or acute just based off of liver enzymes, for example. So there's a ton of information. I mean, we're talking like very bare bones surveillance and still information's missing.
All right. So as those ELR reports come into CalReady, if there were an opportunity to query back, perhaps not to the lab so much, but maybe the EHR of the ordering facility, or a clinical system that knows the patient, and get that additional demographics, race and ethnicity, selected lab results that are relevant to hepatitis C, that would be helpful additions to the process.
That would be huge. Just getting clear race ethnicity data would be a really big deal.
All right.
Yeah, and I think the other thing that I would just quickly add also is, I think right now what's reportable in California is the positive result for antibody and RNA, and then, or genotype, and then negative also for RNA or RNA, but we're not getting negative antibody results, which could also help if we're looking for like seroconversion and things like that, right, Sarah? So I just wanted, like, there's not really a way for us to receive them because the volume is so high. And my understanding is that CalReady, as it stands right now, may not be able to handle that large of a volume.
And those negative results would be on individuals that potentially have never had a positive report, or is that sort of longitudinal data that you're looking for individuals that have already come to your attention?
It is the longitudinal data.
Okay, so someone shows up with a potential case of hepatitis C, and down the road, longitudinally, you may want to go back and look at all of their relevant test results, whether they were positive or negative. Am I getting that right?
Yes.
Okay. All right, before we move on to acute, any other questions from anyone else about the chronic workflow?
Just to recap, make sure that I'm understanding correctly here. So there are basically for Hep C surveillance, there are 3 conditions. One is chronic Hep C condition, acute, and then perinatal infection condition.
Yes.
Based on the categories. And you identify the cases through ELRs, which are positive results for antibody, RNA genotype. I'm not sure if I remember all the things that you have said. And you receive the data from, like, public health lab testing ELRs, as well as the provider reporting ELRs, reportable condition, like, reportable ELRs, right?
Yes, but most of them come from just straight from the laboratories, not just public health laboratories, but like big labs like Quest, AREP, LabCorp. If they have a positive, it comes directly to us without even a provider in the middle of that.
Okay, so the providers could directly send also, but
Yes.
usually it is from all the labs like that report to the state.
Yes, overwhelming, like a majority. I would even go as far to say like 90+% is just straight from ELRs.
Do you have an idea, like, the estimate of volume of data that you're talking about?
That's a good Michael question. Michael, do you have any answer for that? He's looked very extensively at our labs.
So, like, for example, the RStatus program that Sarah talked about, that process that we use to classify cases and then re-upload it back into CalReady, every month there's about 15 to 20,000 incidents. And those mostly correlate with lab results. So it's somewhere in the tens of thousands a month, because we're getting our RNA negatives now as well. RNA positives and antibody positives and genotype positives. So the only thing we're not getting, as Nan mentioned, is the antibody negatives. So since we turned on the RNA negatives, that volume of lab reports has gone up. So it's somewhere in the range of between like around 15 to 20,000 incidents that get created per month. Yeah.
Okay. Everything that comes in an ELR, like, you kind of store as a suspect, and then external process deduplicates and again goes back into CalReady as a case, right?
Correct. It just basically on the back end, CalReady will take the file that we send them, and then they'll update the resolution status of the incidents that need to be updated.
Okay, the status gets updated, only some of them will actually be the cases.
Yeah, could you repeat that last part?
So basically, if I say that, like, 100 ELRs have been received, initially it starts with a suspect, then the deduplication process and verification process happens based on the symptoms or whatever. And after that process happens, some of them go back to CallReady and update the status as a case to follow up or whatever. Okay.
Right.
Yeah.
So because it'll come in, it'll be like auto processed as suspect and auto closed, and then usually it'll change to either confirmed or not a case,
Okay.
or
to do all of the cases though, regardless of whether they're confirmed or not a case, go back into CalReady.
So they're all already in CalReady. It's just a question of whether they're going to get updated or not.
Yeah.
And so not all of them will get updated. But some of them that where the resolution status changes, it will.
Either confirmed or not a case.
Correct. So really the number of actual lab results that we get every month might be a little bit higher than the 15 to 20,000, but it's the majority of results that we do get updated.
Okay. And just one more point that I did not touch upon is only from Los Angeles, the data is externally into processed or received in a file and try to deduplicate, merge, and then gets back added to CallReady, not directly from the lab systems, right?
Go ahead, Sarah.
Oh, I was part of that's correct. So we do get their information separately. It gets merged into this like incident level registry. Then we deduplicate, and then we just sort of know that on the back end. That information never makes its way back into CalReady. So CalReady is void of any Los Angeles data. Although, Michael, you do use that for the, I don't know if this matters, but you do use that for the RStatus program, correct?
Yeah, we use it, like we use the LA data more for the deduplication and to identify if there's any effect of it on existing incidents in CalReady, but it won't create like a new incident in CalReady because there's only like LA data. So we use the LA data for the process of deduplication in the registry, but not to like directly take that data back into CalReady and create an incident there.
Okay, so you don't track basically cases from Los Angeles.
Not in CalReady, but it's in the registry. So
Okay.
we just don't put them in CalReady. That's why we have to create a registry outside of CalReady to track everything.
Yeah,
Okay.
we don't use CalReady. We use our registry. So when I talk about the person level registry and the incident level registry, if you asked me for a data request or the numbers, or we were making a report, we would be using that, not CalReady data at that point.
And the registry is just that R created file.
Yep.
Soon to be Snowflake, right? But it's not a system unto itself, like with the user front end,
Right.
or
No,
okay.
it's just a data
just a
set sitting on
data
the back
set.
end. Yep. Mm-hmm.
Okay, cool. Once CalReady gets updated as either a confirmed case or not a case, what activities happen next? Are they treated differently, or is it just a matter of documenting your findings? Like, are confirmed cases followed up in any way?
I guess kind of, we have another sort of product of the registry, the person level registry, for certain local health jurisdictions that have opted in. We analyze their chronic hepatitis C data to determine whether or not a person is a high priority for hepatitis C linkage to care. And we sort of look at patients for that jurisdiction within a 3-year period. It's not based on the resolution status, so that's why I'm saying there is kind of a follow-up that's related to it, because some confirmed cases can be a high priority for follow-up. But yeah, that is just like another product that we provide to the local health jurisdictions. That is a product of the registry.
What data do you use to make that assessment? Is there, again, additional data coming in that goes into that identification of folks for follow-up, or is that just based on what you've received for ELRs and then anything that you've loaded back into CalReady?
Yeah, it's based on the ELR data that we receive in CalReady. There are also some non-ELR data where local health jurisdictions will just manually enter in lab results in like a separate section that does not come in via ELR. So we'll use that as well to sort of determine priority status in those line lists. But it's all just coming in through that one, actually through our registry, which is pulling from CalReady and other data sources.
Yeah, and I think one thing that would be helpful for that process, because like when we assign priority status, one thing that gets taken into account is their treatment information as well, which we are getting, you know, from CalReady, whether like, I guess it has to be entered by
Yeah.
the LHJ. So like, as we were previously talking about, if that's something that can be more complete in the reports that we get, that could be very helpful for what we're trying to do, the treatment information.
What sort of information does treatment cover? Like, is that medications received, hospitalizations, diagnoses made?
Yeah, there are three main variables in CalReady, and it's just asking, did this person start treatment? Yes, no, unknown. Did this person complete treatment? Yes, no, unknown. And is there evidence of cure? Yes, no, unknown.
And that data you said is manually entered by the local health jurisdictions?
Correct. Mhm.
Okay. And
Sorry, go ahead.
Go ahead,
Greg.
Josie. No, go ahead.
So, my question is, how do they get notified about the status and then enter that information?
I guess it's mainly through their line lists, I guess. We send it to them on a monthly basis and we just let them know, when training them on the line list to prioritize those that are marked as a high priority. Yeah, and then sort of the LHJ follow-up happens within that month. And then if there are any sort of changes to care status, the LHJ will update it within CalReady, but we're not as privy to the follow-up process that the LHJs undergo. Yeah.
What's the nature of that communication? Is that a flat file or a report available in CalReady? How do you convey that?
Yeah, it's an Excel file that we upload through a separate secure file transfer site, so that LHJs can pull it from month to month. And the communication that I have with them is just entirely through email. I just notify them, hey, the file's available through your SFD site. Please log in to download it.
And then their update for those three data elements in CalReady, do they have direct access to CalReady and can enter it in some sort of portal or interface, or do they upload their version of a file that you then import?
They can log in directly to CalReady and update those variables directly.
Okay. And presumably they're calling providers, accessing EHRs to determine whether treatment was started and completed and to accumulate that data?
Yes, that's our like recommendation to them to contact the provider first.
Okay.
I know, but I don't know the extent to which there are LHJs that are providing direct services to clients and finding the information in that way. Because we fund local health jurisdictions as well to do community-based testing and navigation activities. But there's no way for us to know the difference between like whether they're getting the information for providers or getting that information on their own through CalReady.
Got it. Okay.
You send notifications to the LHS, but then the actual uploads of files is automated process to the SFD folders?
No, it's not automated. That's a little bit of a pain point because I generate I generate the files through an R program that's separate from the registry. Then I have to manually upload those files into the SFT site.
And it is based off of the jurisdictions, some category. What is the criteria for grouping those line lists?
Yeah, it's by local health jurisdiction. And there's certain local health jurisdictions that have opted in to receive the line list. So only those
Mhm.
jurisdictions have a folder in the SFT site.
Okay. So is there an onboarding process in case if it's a new?
There is, yes. So we had one big onboarding process in November where local health jurisdictions just completed a survey if they wanted to receive the line list. So that's how I first created the folders. Now it's sort of like a roll on a rolling basis every month. If local health jurisdictions, LHJs are interested, they fill out that same survey to let us know if they'd like to receive the line lists.
Okay.
All right, let's move on to the acute workflow. What does that look like?
It's much easier. So, and then after this, I'll let Michael do perinatal, which is pretty similar, but so acute is it's different. So it's mostly Calready based. The way that we get acute hepatitis C cases reported to us are mainly through provider reporting. That's because I would say like there's a good subset of ELRs that come in as chronic hepatitis C that are auto closed and auto processed that are probably acute cases, but we'll never know because people aren't investigating them. And so providers are the main source of reporting for acute hepatitis C. And also, I think like blood bank clinics would be another place for, and transplant clinics would be another source of reporting. And so for those, though, they come into CalReady as provider reports, and then local health jurisdictions do follow up with all of the acute cases that are reported. So they then investigate the cases, get the medical record. We have a case report form that I can share with you so you can see the data elements that people are trying to complete. And for that, once it's complete, I mean, I pull it out of CalReady and then I create a clean registry for acute hepatitis C where I clean up data or I flag things that need to be fixed in CalReady. But I would say for acute, CalReady is the primary source of investigation. Like if I find an error on the back end when I'm looking at the registry, I go back into CalReady and add the information in. So it's a slightly different in that CalReady is the primary source and that's where all the information is collected.
Our providers reporting today is that paper, phone call, electronic case report, all of the above and more?
Some of them, and Tamara actually might be able to explain this better than I, but so some of them have direct access into CalReady, so they can report directly into CalReady, but they are still also doing faxes. I don't think there's that much phone. Well, I guess there probably is phone calls. I won't rule it out, but I think a lot of the times it's like fax or directly through CalReady.
What's the nature of what they report? Is it pretty bare bones on the initial report, or are you getting most of what you need?
Depends on the local health jurisdiction. Some of them do very extensive jobs of reviewing their cases, and others don't do investigations until I email them and ask them to do it. And I would say there's a lot that goes uninvestigated due to one, loss of follow-up, but two, just because I think not everyone is actively following up with their cases. Oh, and then I did forget though, the other piece of this is there's not only provider reporting, Los Angeles and San Diego counties, they are, like I said before, they are not on CalReady's system for acute hepatitis C. So like if a provider was reporting to them, they would report directly to them and it would go in their system. But what they are doing is they're doing double data entry where they're then entering the cases into CalReady for me after they have already investigated them. So it's a nuance, but I don't think it impacts anything. But it does mean that like I don't think that we would be able to get additional information from any source file for Los Angeles or San Diego because they have a separate system.
All right, so the providers report, you allocate those to the appropriate local health jurisdiction. They do the case follow-up, enter data into CalReady, except in the case of LA and San Diego, where they're probably entering locally and then still entering into CalReady. And that's where the additional case information comes from. Did I get that right?
Sort of, I'm not doing anything. That's all done in
Okay.
CalReady.
Okay.
CalReady assigns, yeah, the jurisdiction when the provider reports it. Tamara, do you want to hop in here? You know that front end way better than I do.
Sorry, the state does it at some point, whether it's human or CalReady, right?
Well, so,
okay, sorry, go ahead.
Nope, that's okay. So the surveillance system has what we call a provider portal. So for certain cases of conditions that are provider reportable, certain local health jurisdictions have opted in and enabled providers in their jurisdictions to be able to access that manual portal for the provider to be able to enter the additional case report information, like that treatment information, risk factors, other things along those lines that they would have collected as part of their visit with the patient. And so, but that is manually entered. So it's in some ways complementary to what Sarah was saying about how the alternative might be that a local jurisdiction would, get that information from the provider via a fax. So for jurisdictions where the providers do not use that provider portal interface, then they would get that information through the fax and then they would manually enter it themselves into the surveillance system. And I think that's all that's kind of the clarification for the provider side of things.
Yeah.
And Craig, you may be on mute or taking notes.
Yeah, I was on mute.
Okay.
Okay, so it's the local, right? So the providers, when they're not direct entering into CalReady, are reporting to the local health jurisdictions who then feed it up to CalReady, and it's the locals that are then doing the additional case follow-up and entering data into the additional data into CalReady. Is that right?
Yes. Yep.
Okay. And then you mentioned some loss to follow-up as sometimes as an outcome. I'm assuming that's because the patient perhaps seeks care other than where the original report was made, or they just can't be found for one reason. They've just recently moved. Is that right? And are there other sources of loss to follow-up?
Yeah, I mean, I think a majority of it is that one of the main risk factors for hepatitis C is injection drug use. So we're dealing with a very, stigmatized, underserved population. And so the way that they sometimes get reported are like through emergency departments or other services, but it's just a population that is very difficult to reach once they have left care. And so I think that is probably more of a factor than some of the other things that you mentioned.
Okay. And those folks, I'm also going to assume are more difficult to identify in other EHR systems or other data sources because the demographics they provide upon emergency room triage may or may not be accurate or may vary. Is that true?
I don't know about that. I feel like
Okay.
in terms of like discrepancies, I don't know that we've looked across like different reports. I mean, I
Okay.
kind of have a little bit, like I just take the most current information that someone has when they touch the system. I don't really pay attention unless it's race and or ethnicity, then I pay attention to what they've reported in the past. And I do see some discrepancies with that, but whether or not that's amplified by that specific population, I don't know.
Okay. That makes sense. Thank you.
Are there any more questions about acute? Because if not, I'll have Michael take it over for perinatal.
Yeah, sorry, I just want to add a comment and highlight, as Sarah mentioned, I think we may be missing a lot of acute cases because they're lumped in with the chronic, right? A lot of them are auto processed and auto closed as chronic. So they are, like we were talking about before, if we can get certain lab results or even like know about seroconversion that we can there are data elements in CalReady that we currently don't get but may be useful for us to pick out acute cases from the chronic cases is also something that I just wanted to highlight if we're talking about like.
So there is a potential that that could be identified from the chronic cases, some of the acute cases.
Yes, because all we need are liver enzymes in order to count cases and or symptom information like jaundice and some other symptoms would be helpful. But like, for example, for 2024, we had 185 cases reported, but it's estimated that there were 2,500 and around 70 cases that should have been reported to us. So we get a very small amount of the acute cases reported to us because it's through provider reporting. And I'm imagining that some of those are also sitting in chronic hepatitis C data. We just don't know because no one investigates them.
How did you get to the estimate as 200, 2,517?
There's a CDC published multiplier where it's for every one case of acute hepatitis C that you have reported, there's 13.9 additional cases. And so I just use that estimate.
Okay.
And it sounds like the ratio of chronic reports through ELR to acute reports through provider reporting is heavily skewed towards chronic. It's that much more prevalent, is it?
Yes, there are a lot of chronic cases. I mean, the acute cases will always be smaller because, chronic is a chronic condition. And so people can be forever infected if they're not picked up along the way or tested. So there's sort of like a pool of people that have chronic hepatitis C that continue to cause acute cases. I mean, also there's another portion of underreporting that's happening because acute hepatitis C can be asymptomatic, and I think the estimate is like 60%, I can't remember off the top of my head, go on and actually clear the virus. So people may actually get acutely infected and then clear and never have a symptom, and they'll never know. But there's also a number of people who have chronic that go on to be chronic and also remain asymptomatic. So underreporting is all over the place. But yeah, in general, there's much more people that have chronic infection that need treatment than there are in terms of acute cases that are arising per year.
All right, thank you. Yeah, let's go on to perinatal now, if we could.
Sure, yeah, I'll take the perinatal. So I think there's a lot of similarities between perinatal Hep C surveillance and acute surveillance in terms of how it works in CalReady, but I'll just maybe say that perinatal hepatitis C has been reportable at an actual case definition since 2018. And it's not as, the case definition itself is not as complicated as acute or chronic. There's no like clinical criteria requirements. It's primarily if you're between the ages of 2 to 36 months of age and you have a positive RNA or genotype result, you're considered confirmed. So what happens in CalReady is, like we've said before, all laboratory reports come in as chronic hepatitis C. So CalReady doesn't currently have advanced auto processing, where it doesn't have advanced auto processing where it kind of can distinguish and assign a perinatal Hep C condition to a lab report for someone who's, let's say, 10 months of age. So because they all come in as chronic hepatitis C, we use CalReady alerts, which is this built-in feature that CalReady has. And we get notifications when there is a chronic Hep C lab result for anyone less than or equal to 36 months of age. And then that is sort of something we encourage local health jurisdictions to set up for themselves so that they can get those emails and notifications. But it's also something that we do at the state, and we review that. So we'll go in and we'll have to manually change the chronic hepatitis C incidence to perinatal hepatitis C in CalReady. So that is a pain point, but it's also the volume of perinatal hepatitis C isn't anywhere as high as it is for chronic hepatitis C. So it's kind of more like maybe in the few hundreds every month, not in the tens of thousands. So that's one difference between acute and perinatal. There is like this sort of manual component of the alerts and reviewing cases. And you know, it perinatal hepatitis C kind of still struggles with the same issue that Sarah was mentioning earlier, where we can't just take the data straight out of CalReady. Although it is less susceptible to some of the issues, it still kind of suffers from deduplication problems and some of the other things that, just from a longitudinal standpoint, CalReady doesn't really deal super well with. And then let me see if there's anything else. Perinatal Hep C is also underreported, kind of similar to acute hepatitis C. It's also asymptomatic. It's usually rare for infants or children to show symptoms that are consistent with hepatitis. So oftentimes there may be a lack of provider awareness for doing testing. And because of that, cases go pretty underreported. I think nationally there's somewhere around 200 to 220 cases that get reported as confirmed per year, but there's an analysis that CDC did a few years ago that estimates the annual number to be more like 1,700 infants, with some confidence intervals around there. It is a little bit outdated estimate, but it kind of gets at the idea that it's underreported as well. And then similar with acute hepatitis C, San Diego and Los Angeles also manually input their perinatal hepatitis C cases into CalReady. So I'll pause there and see if there's any questions.
Those notifications you get, I think you said they're kind of in the form of an email. Is that right?
Correct. They're called CalReady alerts, and it's something that we just gave a training on this to local jurisdictions. They can go into CalReady and sort of set that up for themselves. And so once that lab report comes in and gets processed, an email will go out That'll tell them what the incident is and how they can access the incident to review it.
All right. And then are those reports flagged in CalReady as being perinatal? Do you do anything specific with those in CalReady once you've gotten the alert and done the investigation?
From our perspective, usually I'll give some like a 2 weeks to see if the local health jurisdiction is going to make changes. And if because not every local health jurisdiction does active surveillance on their perinatal cases. So if it's a non-positive result, usually either they'll close it as not a case or I'll close it as not a case. But if there's additional testing that needs to happen or additional investigation, I will be sending out an email to them to let them know that there's this sort of incident that needs follow-up, and then they'll kind of go from there based on their capacity.
And that investigation, I'm assuming, is relatively similar to acute in they call the provider or they have access to a medical record and they're looking for confirmatory results, symptoms, that sort of thing, treatments.
Correct. And some local health jurisdictions will actually follow the birthing parents and will identify that there's someone who's pregnant who has hepatitis C, and then sometimes they'll actually preemptively create a perinatal hepatitis C incident for future testing to happen. But there aren't a lot of local health jurisdictions sort of that do that level of enhanced case follow-up.
All right, so linking from the individual, the infant, back to the parent record to look for that history, it sounds like, is sometimes done. Did I hear that right?
Yeah, and Hammer, I don't know if there's anything you want to add. I know you came off mute a couple times and are typing, but before I answer that, I'll give a second.
No, I think so. Yeah, and I was just going to, I think, clarify. And Craig, maybe I misunderstood your question, but so within the surveillance system, hepatitis C perinatal is a unique condition that can be assigned to a case. So it can be assigned as hepatitis C chronic or hepatitis C acute or hepatitis C perinatal. And so what Michael was walking through is, those perinatal cases may initially come into the system as hepatitis C chronic, but then be reassigned to the perinatal condition based on the age. But that has to happen manually.
Understood.
Yeah, and to that point, similar to the other conditions, sometimes there's provider reporting, or someone from a local health jurisdiction might go in and manually create a perinatal hepatitis C incident to begin with. So that is an option, and that wouldn't be like ELR based. That would just be them doing it manually. And the majority of, I think, our incidents that exist in CalReady, the perinatal incidents at least are still lab based or ELR based. So as far as linking to the birthing parent, that is something that is a little bit difficult to do. And I'm thinking of some other conditions like congenital syphilis, where I think that they have better completeness. There is an option in CalReady to like put the birthing parent's incident ID, but it's one of those things where it has high levels of missing values. And we haven't done sort of a match with vital statistics, birth records. And so like Sarah mentioned earlier, that might be a version 2 or version 3 thing. And there's also a place in the chronic hepatitis C incident to put down a perinatal hepatitis C incident if you want to link from the chronic incident to the perinatal incident, but those aren't fields that we're actively using in terms of communicating to local health jurisdictions, because there's a lot of missingness.
All right, thank you for that. Any other questions regarding perinatal? Otherwise, we'll maybe move on to just some wrap-up review. All right, thank you for all of that good discussion. I think we've got a good description of what's going on feel like we've heard a lot about the actors that are involved in what you're doing today, where data comes in and where there may be triggers for case investigations, got a good sense of the payload and the downstream usage. Can you talk a little bit? I know you've mentioned a few things that are manual or painful or just a gap today. Anything else that you haven't really talked about that is really takes a lot of your time or is inconsistent or just plain missing that would be nice?
I have a thought, but not. I was going to see if you guys have any pain points first.
I can't think of anything that we already didn't mention, so you start, Sarah.
Yeah, and then I'll just open the floodgates. No, Jocelyn has had this pain point too, so she gets it. But one of the things that's kind of annoying, and I haven't really set up. I think I could probably set something up to do this, and I'm not sure there's any way around this. But because of the fact that a provider might report an acute case into CalReady, but the lab result for that acute case could still be auto-processed, auto-closed as chronic. And so at the end of every year when we're doing closeout, one of us has to go in and we have to see if our acute case was actually is also reported in our chronic data. And it can kind of go both ways. Like a provider can also report an acute case to us, but then we find a chronic report for them that was earlier than the acute case. And so we need to then move them to chronic. And then, or the other thing that happens is we go in and we find a ELR for the for the acute case that was reported after the acute case was reported. So then we need to move that information over to acute. And it's just a pain point. It takes way longer than it should. You're going through like 200 records trying to do that. And I think that every year, I think Jocelyn could probably agree with me because she's done it. It's just not fun. So that is like a big pain point that we do. And probably should do more frequently, so it's not all just at the end of the year, but it's a pain, and I just really don't like doing it.
Are there any rules around it, like the date and times or the lab reporting times that you use to identify those?
There could be, yes, but right now they're all just mental rules that Jocelyn and I hold. We haven't built out a process for. I do have a process. I mean, I match them, and then right now we just manually review and say, okay, this lab was reported before this. The chronic lab was before the acute one, so therefore they're probably chronic. Or okay, the chronic lab was reported after the acute one, so they're probably acute, but you still have to like merge them together, which I don't think that solution will ever, there'll ever be a nice solution to that. But yeah, that's what we do right now.
And you see there is a potential based if we come up with proper business rules and before merging, identifying them.
Yeah, potentially.
To automate the process.
I don't know. Mostly if we were just talking about pain points, I was bringing that up in the case that you did have solutions to it.
I'm gonna add to what Sarah said about the manual review process. Another sort of pain point is that within CalReady, there is an option where local jurisdictions can upload PDFs of lab reports to like a separate sort of, I guess, folder within CalReady. And because of that, that information does not get transferred into the fields that Sarah uses to analyze those data and to determine if the acute case classification is met. So that's more like training for LHJs. Like we've been telling them to please transfer that information from those files into the CalReady fields. But yeah, that's just another little thing that we're working around.
Yeah, that was going to be the next thing I was going to say. And that's not
Nice.
unique to our condition either, but they upload, I mean, they can upload medical records or labs into the electronic filing cabinet, and we have, you know, in order for us to review these cases, you have to go in, review the file, and then enter the information for them. When I'm literally just looking for like, there are very specific fields that I'm looking at in order to classify a case, and I think some of that could like we looked at ECR as a way to solve some of this as well. But I think some of that information, if it could just get pulled directly from another source without us having to manually go in and review, that would be great.
Where do you see some of the benefits to the program? Obviously, it would save your program staff some time if you had better access to data. Maybe some of these were automated. Sounds like the local health jurisdictions are doing a lot of the heavy lifting in terms of follow-up and looking for treatments. So where do you see the real benefits to more automated solutions to data access?
Well, certainly for acute cases, if there was a way for the local health jurisdictions to not have to not try to hunt down all the information that we're trying to get for acute hepatitis C, that would be beneficial. It would save them time, right? If they're going in and they're able to automatically see, especially the basic fields that are needed completed, and the loss of follow-ups. I mean, those are a lot of time too. I just think the more information that one can acquire automatically saves all of us time across the board.
And if that information were in CalReady, the local health jurisdictions could access it there, or could at least be part of the reports that you generate for them?
Yes.
Okay.
Non, you were about to say something, I think.
Oh, no, I was also gonna say, you know, it would also improve our accuracy for, you know, our accounts as well. As in what Sarah and Jocelyn was talking about, like if some of the acute cases are in chronic and then some of the chronic cases have, yeah, so like just improve the accuracy for our surveillance overall.
Where does timeliness fit into this? I'm assuming, is it the acute cases and perhaps the perinatal ones that it's important to have that information as soon as possible? Or how fast do you like to get these individuals in treatment if they're prioritized for that?
Yeah, I mean, the sooner the better, right? And I think maybe even if there was less information gathering, it might be easier for people to focus more on linkage to treatment as opposed to just like giving us information. Because I can't tell you that always happens, even though I think people try. But even, you know, I expect people to follow up with cases and be completed with them within a month of receiving them. I think that's pretty lenient, but then you also have like a whole swath of, you know, we have 30,000 chronic hepatitis C cases reported 1 year. And if no one's following up with any of them, which that's true because some people are, but let's just say no one is, then none of them are getting linked to treatment. So I think if you could get more information in those files too, it might encourage local health jurisdictions to link people to treatment and actually review that data as opposed to what they're doing now because they don't want to investigate because the volume's too high.
And then,
Right.
sorry, I was just thinking about one thing. Sarah, I'm probably not going to articulate it very well, but the one thing that I think we're still trying to do is reporting like of some information like risk factors to CDC. That is kind of not happening because of the technological limitations. Like I'm trying to describe the MMG process, Sarah.
Yeah, I'm like, Tamara, I feel like you might be this has been going on for like 10 plus years, how our systems don't talk to each other.
Yeah, I wouldn't be able to address that. I think that if we were interested in exploring that, I think that that would be definitely a conversation I'd bring Mary Joyce into, since she is our person who does all of the case reporting to the CDC and implementation of message mapping guides.
Yeah, so I think, I wasn't trying to just single out MMG, but like I think we still have we could also use, there's also pain points in like our State Department like jurisdiction reporting data to CDC, and we would like to be able to send more complete data elements to CDC as well.
So that would be things that a provider might document in their EHR system that you say are risk factors, whether that's occupation or behaviors or other social impactors of health. Is that what you're thinking?
Yeah, so they will be in the case report forms that are filled out by the providers.
Okay. All right, one last question for me, and then we'll see if anyone else has anything more to share. Is there an HIE or some other network that operates within California that collects data that would be a potential source of data to query for some of this, or is it all really going back to the provider EHR systems?
Say that again, Craig. Could you repeat that?
Is there a California Health Information Exchange, HIE, that aggregates data on individuals? Okay, so you're always going back to the provider systems?
There, I think that's probably true. We have several HIEs that tend to be regional in California, but I don't know the extent to which they communicate with each other, and or that at least local jurisdictions may get data from some of those regional HIEs.
All right, thank you. All right, any other questions to ask the Hep C folks? Anything else that we haven't covered that you think is critical to what you do and how you do it?
Maybe a very high level, like how are you receiving ELRs from these systems, like through HL7 or?
Yeah, we are. We almost all of the labs in California are doing ELR. And we have a centralized what we call a front door that has the connection to the labs or to EPHL or Stream. Yeah. So the various sources where the labs come from.
Okay.
And we also use that same front door for receiving electronic initial case reports.
Oh, ECRs. Okay.
Okay. So you are getting ECRs, and do they feed into CalReady?
They do.
Too?
Yeah.
Okay.
Yes.
So these initial reports could either be ELR, ECR, or the manually entered?
Correct. Oh, go ahead. Sorry.
I was gonna say
Nancy.
for hepatitis C, the ECR is not, we're not getting them yet, right?
Oh, okay.
I was just going to say, yeah, we're rolling out the conditions that we're processing EICRs first in an iterative fashion based on a variety of criteria. And I was going to need to follow up and see if we were doing EICR for hepatitis C, but it sounds like we're not yet.
Not yet, yep.
Okay, that's good information.
So once you probably start processing ECR, that additional treatment information, all that stuff may be available, right? Potentially, you have that through
Potentially.
ECR. Yeah.
That's,
Mhm.
yes.
Well, I mean, it comes with the caveat that all ECR comes with, right?
Right.
Yeah.
All right, anything else? All right, thank you so much for your time. This has been great. As we mentioned before, the next step is we'll take the outcome of this discussion and then we will translate it into a high-level non-technical template that we have, and then we will share that back with you to make sure that we accurately reflected what you told us. And if there's anything else that comes to mind, please do feel free to reach out and we'll incorporate it into the write-up. How does that sound?
Sounds good.
Sounds good. Thank you.
Yeah.
All right. Well, again, thank you for your time. We appreciate you talking with us.
Thank you.
Thank you very much.
Thank you.